Good evening, everyone. First of all, let me thank Professor Vita for the kind invitation once again. So in the next few minutes, I'd like to talk with you about this interesting topic. I have nothing to disclose for this talk. Arch pathologies are uncommon, and the vast majority of them are based on aneurysms, acute, subacute, and chronic dissections. Today, open repair, especially for young and fit patients, remains the gold standard of care for complete aortic arch replacement requiring sternotomy, hypothermic circulatory arrest, and cardiopulmonary bypass. For this reason, older patients with high comorbidity are now excluded for this kind of treatment for the high risk of mortality and morbidity related to this kind of surgery. So how can we treat this kind of patient with some hybrid technique, different hybrid techniques with hemi-arch transposition or total arch transposition, like in this case of a patient who presented a dilatation of ascending aorta, a huge aneurysm of aortic arch, and involving the descending thoracic aorta. This patient was treated with open surgery first, with in the first step left carotid subclavian bypass, and seven days later he did an aortic valve repair, ascending aorta replacement, and debranching for innominate artery and the left common carotid artery. Three days later, the aneurysm was successfully excluded with 2 thoracic stent grafts landing in the Dacron graft in ascending aorta. This is another case of total arch transposition with a bypass to left subclavian artery and the reimplantation of common carotid artery with Dacron 8 millimeter tube graft. But also this kind of treatment presents a high risk of mortality and morbidity, especially in patients with severe comorbidity were reported in different series and experiences. So more than 40% of patients are unfit for hybrid repair and remain untreated or with an incomplete treatment. But thanks to the endovascular evolution, thanks to the improvement of material, now we can treat this kind of patients with severe comorbidity with total endovascular approach using new materials, new custom-made materials. With the possibility to make homemade fenestration, especially in case of emergency situations. With this kind of treatment, give us the possibility to have as more smooth post-operative course, especially in case of older patients with severe comorbidities. And this is very important. In our experience, in the last 5 years, we treated 218 patients with thoracic aorta disease, 177 patients with totally percutaneous approach and unconscious sedation anesthesia. This is our protocol of anesthesia with the patient collaborative and awake. And this is very important, especially for old patients. And those are our results with 1% of mortality, 1% of neurological events, 1 case of a retrograde dissection, and in 10% conversion to general anesthesia. So in conclusion, for young patients, open repair remain the first option. For patients unfit for surgery, minimally approach of the thoracic aorta with the sealing area in the arch seems to be feasible and effective. Using a homemade fenestration is possible to treat high-risk patients also in urgent and emergent setting. Thank you for your listening.